Hi Achievers, welcome back. We are now discussing all the MCQs which have come in the last 2 years and are likely to repeat themselves in any entrance exam. You're having an exam on 17th of January. Let's see how many of these topics come in exams. I'm trying to make an effort of simply recalling the few questions which have come in the last 2 years, and I hope we hit at least some of them in the exams. Right? So let's see the first question. What is the first maneuver used in the management of shoulder dystocia? So shoulder dystocia, the head is come out, but the shoulder is stuck. And if there is a more than 60-second delay from the delivery of the head and the shoulder has not come out yet, so we say that is shoulder dystocia. And the first thing is to hyperflex the hip joint more than 90 degrees. Mac Roberts maneuver. Please, suprapubic pressure is the next one which we do. It is also known as the Rubin's first maneuver, the suprapubic pressure. So always say the Mac Roberts maneuver, hyperflexion of the hip joint more than 90 degrees flexion of the hip joint. Okay, guys. So yes, if that does not work, then we can do the Woods corkscrew maneuver. If that doesn't work, we can do the Gaskins all four maneuver. But the last thing which we have to do, if nothing works, is to push the head back inside and do a cesarean section, which is known as the Javanese restitution. Right. Let's move on to the next one. A 30-year-old woman has postpartum hemorrhage, not controlled with uterine massage and uterotonics. What is the next best step? So whenever we talk about PPH, we will always say that whenever a bleeding is not controlled by the drugs, then we have to go for surgical maneuvers. But remember, while you're giving the drugs, you're not leaving the woman. What are you doing? You have one hand in the vagina, one hand on the abdomen, and you're giving a gentle uterine massage. Yes, while you're doing the PPH management, that time itself you have to do. That time also you have to do uterine massage. Remember, in active management of third stage labor, again, you have always got to do uterine massage. So there is no doubts about this one. Uterine massage done for the prevention of PPH and definitely done for the management of PPH. Now, if that is not working, what do you do? You are trying to give the drugs and the uterine massage. If that is not working, what do you do? Surgical management. And the surgical management is first one is to give a balloon tamponade. So Bakri balloon, you fill the balloon with 500 ml normal saline. Right, guys? So, yes, let's see the next one. What is the earliest mental sign of uterine rupture in a woman who is undergoing a trial of labor after cesarean section? Remember, once a woman had a cesarean, she can deliver vaginally if there is no CPD. Yes, previous one LACS. Yes, Royal College says that you can do it after two LACS, but we are not Royal College. We are the Indian hospitals, and what we are following, previous one LACS, give a trial. So there are a lot of recommendations coming in the American College and the Royal College and the WHO and the CDC Atlanta. So what are you going to follow? What is done in your medical colleges? Look, lot of updates come regularly. Every 3 minutes, one new update comes up on the internet. What are we going to follow? What is practice in the medical colleges of a country? You have to know your core basics. Install the basic software, guys, first. The updates will keep coming, but are you good with the understanding of the basic, the core basics? Then only we are bothering you with the updates. When you become postgraduates, I'll be asking you updates every day when you're taking rounds with me, even when you become interns. But very, very important, all the updates which are coming every 2 months, something comes up on the internet, and every 3 months something comes on these guidelines. Those are not to be ignored, but they have to be followed only when the Ministry of Health and Family Welfare says, okay, fine, go ahead. Now, this is going to be the practice in our country. Till then, they are not important. Please remember, updates are to be used only when they are implemented. Very, very important. All right. So, yes, what are you going to do when a woman is undergoing a trial of labor and there is a rupture probably happening? So what is the sign of imminent rupture? Suprapubic tenderness. Now, if the rupture has happened, if the woman has ruptured the uterus, what is the first thing whenever anybody bleeds? The person has tachycardia to compensate for the loss of blood. So first sign is the maternal tachycardia. So fetal sign, if they ask, first fetal sign of rupture. Now that is a different question. If they ask you the fetal sign of rupture, then that is the variable deceleration. And after that, there is a late deceleration. And lastly, there is the bradycardia. Don't get that wrong, guys. First sign in the mother is maternal tachycardia. In the fetus, it is the variable deceleration of the heart. Right. Let's move on and see the next one. Bandal's ring is associated with what? So there is a physiological retraction ring and this is a pathological retraction ring. So yes, Bandal ring is the pathological retraction ring. The physiological retraction ring is normally seen in all labors between the upper, yes, the upper contracting segment and the lower relaxing segment. We have done that many times in the classes. That's why this revision is a little fast, but I'm sure that you are correlating well. So look at this picture. The isthmus. Isthmus is made here, you can see, by the anatomical interloss and the histological interloss. The area between that, it is 0.5 centimeters, and it becomes the lower segment in labor, and this upper segment contracts and the lower segment will relax. Lower segment will relax. See, active upper segment and passive lower segment. So when the patient is in labor, you see the physiological, see this line, physiological retraction ring here. This is the physiological retraction ring here. But if there is second stage dystocia, abnormal labor, the uterus is contracting on a big baby which is not able to enter into the pelvis. So uterus goes on contracting, but the head does not get into the pelvis. Then we say it is a cephalopelvic disproportion, but still the uterus goes on contracting. So uterus gets bunched up and the retraction ring goes much higher. So that is what is known as the pathological retraction ring. Bandal's ring. Yes, like we told you in the previous screen, it's the Bandal's ring, and it is much higher. It is higher and you can feel it. It is felt per abdomen. You can feel it from the maternal abdomen, although the physiological retraction ring can be felt only from a vaginal examination. Pathological retraction ring is higher and it is felt by the doctor in by through the maternal abdomen. Now, which type of pelvis is associated with increased incidence of face to pubis delivery? This question is coming for the last 3 years. It has come out of the 6 exams, it's come in three. So, yes, the pelvis which is gynecoid rotation is possible. The pelvis which is anthropoid rotation is not possible. So, in anthropoid pelvis, you will see face to pubis. Let's see this picture here. All of you know that the gynecoid pelvis is nice and round inlet. So, if there is a occipito-posterior, rotation is possible. So rotation is possible in a case of a gynecoid pelvis. But can you see the side walls are parallel in a case of a anthropoid pelvis? So this is the second most common type of a pelvis. Most common type of pelvis is the gynecoid, and the rarest type of pelvis is the platyploid. So in a case of an anthropoid pelvis, if this arrow is the occiput, this rotation is not possible. No rotation is possible. So that's why the baby's occiput stays posterior and the face will be looking upwards. Yes, you're not able to make out anything without this. All right, guys, we'll see. Okay, so this is the outlet of the pelvis, this is the pubic symphysis, this is the sacrum, and this is the occiput. Can you see why is this the occiput? Because you're seeing the lambda here, the triangular suture here. So this is the occiput. So this is occipito anterior. So how does occipito anterior deliver? It delivers by extension. All of you know that. So where's the face of the baby? The face of the baby is looking at the mother's sacrum, isn't it? That is what is the normal method of delivery of any occipito anterior. But now, if this is occipito posterior like this, and if it stays occipito-posterior, like in a case of an anthropoid pelvis, if it stays occipito-posterior, it will still deliver. But this, can you see the occipito-posterior is delivered? But can you see where is the face looking? The face is looking towards the maternal pubic symphysis. So that's why if it is occipito-posterior and it delivers as occipito-posterior, then we say it will deliver with face to pubis. So anthropoid pelvis, face to pubis. And android pelvis, only partial rotation is possible. So it rotates from occipito-posterior to occipito-transverse and stops. So rotates to occipito-transverse and stops. So when this stops, then next what you have to do? Yes, you have to do a manual rotation plus a forceps extraction. Yes, this has not come. This part, android pelvis part, has not come in exam. But anthropoid pelvis, you should know that is the second most common type of pelvis. And in that, if there is a occipito-posterior, it cannot rotate to occipito-anterior. These are your questions. Okay, guys, hot shot, and you should know. Okay, let's move. Now, the question of the evening. Arrange in sequence for active management of third stage of labor. Remember, whenever the baby comes out, the broadest part of the baby is the bipedal diameter. The next broadest are the shoulders. So, moment the baby comes out, you take out the anti-shoulder, and moment the anti-shoulder comes out, you're sure that this delivery will complete. So, you give oxytocin. That's the time when you do this. But yes, make sure that there's no other baby inside, because if there's another baby inside, the oxytocin is going to contract the uterus, and the second baby will get hypoxic damage. So we always give only when there is first baby, then at the delivery of the anti-shoulder. Otherwise, if they're twins, then you have to give it on the delivery of the anti-shoulder of the second baby. Right. So we're talking only about the singleton. So when the baby's head is out, you deliver the anti-shoulder and give the oxytocin. Make sure there's no second baby, and then you give oxytocin 10 units intramuscularly. You can also give it intravenously. Control contraction, and then what do? You do uterine massage. This was INICT question, and I hope you're not going to disregard the major colleges of the country: AIMS, JIPMER, and PGI Chandigarh. These are the people who asked you this question, and uterine massage is done. As simple as that. Yes, I know that WHO says that you should not do uterine massage. Ever since 2012, those recommendations are there. In fact, even in late 2025, some new recommendations came in which they are again saying that don't do uterine massage. Yes, we know that, but what does the government of India says? So the answer to this question is ABCD. And what does the government of India says? That you must give uterine massage. This picture from the Ministry of Health and Family Welfare, this is telling you what are the steps of active management of third stage of labor. This is what Ministry of Health and Family Welfare says. If WHO says something, we are not going to disregard it, but we are not going to implement it immediately. Like I told you earlier in this chapter, that if there are new recommendations, until unless the Ministry of Health and Family Welfare or the medical colleges accept them, we are not going to teach you those. We are waiting for you to know the core basics. The updates will keep coming all your life when you become postgraduates. All right. So you should know the core basics. And what does the government of India want to do for the active management of third stage of labor? Injection oxytocin, and then control contraction and uterine massage. You have to do that. And if you don't believe me, see that in Hindi also. They've given it in all the medical colleges. I want to show you something. I think after this, you should not have any doubts. The same picture which I showed you in the previous screen, if you just highlight what is given in the bottom of this picture, just I'm blowing it up a little bit for you. For use in medical colleges, district hospitals, and all first response units. For use in medical colleges. This come from the government of India to be put in front of all the labor rooms of medical colleges. You can go to any medical college and you can see this picture there or something similar. Private hospitals also keep this, but they write this in their own format, but they have to write the same thing because they all manage the same way. So let's not get confused, guys. Just 1 or 8 9 days before the exams, I don't want you guys to get any confusion. Uterine massage is coming in the exams because you're supposed to do it, not because of you are not supposed to do it. Okay, guys. By the way, WHO also says that what is best these days, that you encourage the mother to do a self-assessment of the uterine tone. Are you going to be doing that in the labor rooms where you are working? Are you going to follow self-assessment? That means the mother puts her hand on the abdomen and looks for the uterus to be contracted. And if it is contracted, fine. If it is not contracted, call the doctor. Hey, my uterus is flabby and it is bleeding. Is that the management you're going to follow just because WHO says? So we are not anti-WHO, but we cannot follow that in our country because we have enough doctors. What happens? WHO is giving recommendations for many places where there are less doctors. So they don't want one doctor to be occupied by just doing uterine massage. I agree with them, but I don't implement that. We follow what the government of India says. Enough on this. Let's move on, guys. In which case we can extend medical termination of pregnancy beyond 24 weeks of gestation. Only one condition, and that is uterine anomalies which are not compatible with normal life. Yes, be careful of this statement. Congenital anomalies only. Contraception failure, you can do till 20 weeks. If a woman has got, let's say Down syndrome, has got VSD, and she wants to terminate a baby, we can do till 24 weeks. If the woman has got raped, we can terminate till 24 weeks. But if there are gross anomalies, only then after 24 weeks you can terminate the baby. Like the baby is anencephalic, he's not going to make it, and you diagnose that pregnancy with anencephaly only, let's say 28 weeks, because this woman came to you from a village and she did not know that she's got an anencephalic baby. So if you diagnose that even at 28 weeks, you can abort the child. But a board which should have a gynecologist, radiologist, pediatrician, and a government approved person. So four people should approve that this congenital anomaly is not viable with life. So that's the condition where you'll do. In, just remember one thing: if a woman comes to you at 26 weeks and on the ultrasound you see a VSD and rest everything is fine, and she says, "Oh, my child has an anomaly, please abort." I cannot abort for a VSD at 26 weeks. Any anomaly coming before 24 weeks, we can, yes, go ahead and do an abortion. She has a right. After 24 weeks, if she comes with a VSD, which is compatible with life, yes, VSD might be a small muscular defect and the baby will do just fine. Or good pediatric cardiologist can take care of those things. So please understand, only anomalies which are not compatible with life after 24 weeks. Like, for example, if even if there's a Down syndrome, you diagnose after 24 weeks. Yes, Down syndrome babies will live. Yes, they have a short life. We agree. But you cannot abort for a Down syndrome at 26, 27 weeks. All of that is before 24. Only anomalies which are non-compatible with life, those you can abort after 24 weeks. Is that fine line? Okay, guys? Chalo, let's move on. All the clotting factors are increased in pregnancy, except, yes, pregnancy is a stage where you want the clotting to be increased, because moment the plaster separates, the base of plaster bleeds and cause PPH. So I want good clotting there. So pregnancy increases clotting. Wonderful arrangement by nature, isn't it? So yes, all the clotting factors increase except 11 and 13. These both don't increase. So answer is this one. Next question, fatafat. What is a reactive non-stress test? Reactive non-stress test, that it's fetal surveillance. Guys, please do not leave your homes if you've not read fetal surveillance. If you've done gynae and you don't remember fetal surveillance, please give my fetal surveillance topic another one look. It'll take 15 to 20 minutes if you've read it once at least. So please read fetal surveillance. Do not leave your homes without reading fetal surveillance. Question will come. Definite, pakka, guaranteed. NST, biophysical profile, Doppler, cardiotocography, something's going to come, or maybe daily fetal movement count is going to come. So, what is a non-reactive NST? What is a non-stress test? Non-stress test is that when the baby moves, his heart rate should increase. How much should it increase? It should increase at least 15 beats. How long? How much it should last? It should last 15 seconds, and it should happen at least twice in a 20-minute observation study. All right, guys. So that's a reactive NST. See, there's a movement and there's acceleration, then there's another movement, there's another acceleration. So this acceleration and this acceleration, two accelerations in 20 minutes, that means it's a reactive NST. This is normal. Now what is this? Now this is not a non-stress test. There are two probes. One is telling me the fetal heart rate. Other one is telling me uterine contractions. So yes, so I have given you both of these together so that you know, they will ask you, they'll just show a mother lying down with one belt on the tummy, NST, two belts on the tummy, cardiotocography. What is cardiotocography? Along with the uterine contractions, see the fetal heart rate. So these are the uterine contractions. Here, I'll show you another color. See, these are the uterine contractions. And along with that, what happens to the heart rate? Can you see that? I have rounded them up a little bit for easy understanding. So when the uterus contracts, the peak of the contraction is not coinciding with the lowest heart rate. So this is late. This is late. So this is example of a late deceleration. So this is not normal. Late deceleration is not normal. Early deceleration is seen normally in labor. It is because of head compression, and variable deceleration is the most common deceleration because of umbilical cord compression, which is mostly normal. Okay, if you didn't hear it properly, rewind and play it again. Okay, guys, let's move. So, what is the biophysical profile? Favorite question again. You know that the non-stress test you were doing with that belt, but on the ultrasound, you can check for the fetal movement and the fetal breathing, fetal tone, and the amniotic fluid index. So, fetal breathing is basically the swallowing. The baby is swallowing amniotic fluid regularly. So that swallowing movement looks like the chest is getting expanded, looks like breathing on the ultrasound. So baby is not breathing inside the mother's uterus, obviously. but the swallowing of the baby looks like a breathing movement. So all of these are given 2 points each, and 10 by 10 is a perfect biophysical profile. And if it is 8 by 10, we say it's a okay, chalta hai biophysical profile, provide the NST, or and provided the amniotic fluid index is good. And if it is 6 by 10 or lesser, then it's a compromised. It's a compromised fetus. All right. So yes, less than 6 by 10 or lesser is not a very good biophysical profile. So yes, what is the normal amniotic fluid index? We'll come into that one. But amniotic fluid index is the sum of all the four Leica pockets, the cord-free Leica pockets in the uterus. All right. So let's move on and see the placentas. This placenta is the circumvallate placenta. One of my patients were delivered around 3 years back. This is got, can you see the membranes here on the periphery? These membranes, can you see these membranes are folded because the chorion is small, the chorion, the placenta is small, and the membranes are folded on the periphery, circumvallate. It is associated with abruption and IUGR and preterm labor. Abruption is your MCQ, guys. Let's move on and see the next one. This is a placenta where you can see one lower placenta like this, another small lower placenta like this. So that is the succenturiate lobe. And the succenturiate lobe, all of you guys, you know that you take out the big placenta, but you don't know there's another small placenta which stays back inside. And she presents with, yes, like a retained bit of placenta, and the patient will have secondary PPH. What is the management of secondary PPH? Don't say manual removal, because secondary PPH presents to you after 2, 3, 4 weeks. So when she comes with secondary PPH, forget putting your hand, you can't even put your finger inside, isn't it? So secondary PPH, you have to do a curettage. And if you're doing over enthusiastic curettage, yes, Sasherman syndrome. Okay. So you guys remember all of that. Succenturiate lobe is also known as the accessory lobe. Yes, what is this one? This is a marginal insertion. A marginal insertion, or the battledore placenta. The cord may get snapped while you're doing the delivery of the placenta. Right, guys? So, and the hotshot picture of the evening. Yes, this is the slide on which you're seeing a lot of vaginal epithelial cells which are embedded with hundreds of bacteria. This is known as the clue cell. Clue cell seen in bacterial vaginosis, most common vaginosis, and there is no itching, and treat only the lady. The male partner does not need to be treated in this because it is not sexually transmitted. Trichomoniasis, you must treat the male partner. In trichomoniasis, there's a lot of itching. Candidiasis, there's a lot of itching, but bacterial vaginosis, there's no itching. Treatment of trichomoniasis and of bacterial vaginosis, both is the metronidazole. But yes, in bacterial vaginosis, you must know the five AMSELS criteria. You must know that because three or more of these are required for the diagnosis. So alkaline pH, creamy white discharge, fishy odor, whiff test, and clue cells. So any three of these is the diagnosis of the bacterial vaginosis. Must read about this one. I've given you, wherever I've taken a session for you, you guys know that I've given you a chart of all these three together and comparative findings and the things which are common and things which are different amongst all these three. Please mug up that chart. It is coming in the exams. One of them is coming in the exams. Then what is bishop score? Pada ki nahi pada? Guys, bishop score, okay? Please ratta marna hai. You have to know bishop score. If you have not remembered this much, then you have to mug it up. The bishop score, I'm just here to remind you. You have to know about this because one question comes in every three exams. Maybe this is that exam because it's not come in the last exam. So remember bishop score. You have to know this in your mind. They'll give you the findings. Cervix is 2 centimeters dilated. Station is -2. It is medium in consistency. It is central, and you have to know the bishop score. So good bishop score is anything more than 9. More than equal to 9 is a good bishop score, and less than equal to 6 is a poor bishop score. All right, guys. So must read bishop score. Then, when is the Leica maximum in pregnancy? Again, it's not going to come in the exam every time, but this is the question which you guys are always worried. Please remember, Leica is always going to reduce after 34 weeks. 36-week onwards, it is reducing, and at term, it is lesser. Don't say Leica keeps increasing till 40 weeks. No, not at all. It reduces after 34 weeks. So Liker is constantly increasing till 32 to 34 weeks. So the choice given in your exams was not 32 to 34. They had given 28, 32, 36, 40. So if you have to pick up one of these, you have to go and pick up 32 weeks is the maximum Liker. So I'm showing you the picture from the American College of Obstetrics and Gynecology, and this is giving us the picture which should make you understand. So like the you see the 99th centile, the 95th, 75th, 50th centile, all of these centiles which you see, the Liker is maximum between 32 to 34 weeks. This is the picture here. If you see this 32 to 34 weeks, you can see the Liker is maximum here. See, this is the maximum Liker. You can all make out 32 to 34, but you have to choose one of them. So 32 and 34 won't come in the exam. I remember this came in the December 2022 exam, which was conducted in January 2023, and they had given you 28, 32, 36, and 40. They had not given you 34. So one of them you have to mark 32 to 34 if they give you, and that you have to mark 32 because it came in MCI exam. That's the only reason, because it is 32 to 34 is the range. That's it. I mean, they are not going to give you a choice between 32 to 34 because this is what is normal. One of them will come in the exam. Okay, guys, let's move on. Most common position of vertex. Okay, quickly we're finishing this. Most common position of vertex is left occipital transverse. 40% of all pregnancies are in left occipital transverse. Most common malposition, right occipital posterior. Most common mode of delivery in occipital posterior. I mean to say mode of delivery in occipital posterior. Occipital posterior, please don't say cesarean section. I'll commit suicide if you say that. Please, all of you have gone through with me, you know that occipital anterior, look here, quickly we'll revise. Occipital anterior delivers by extension. If it is right occipital posterior, see, it is towards the, okay, right occipital posterior. If it is a case of right occipital posterior, can you see it's towards the right, the occiput? So if it's a case of right occipital posterior, hits the pelvic floor, it rotates to occipital transverse, occipital anterior, and then directly occipital anterior, and that also delivers by extension. So most occipital posteriors will become occipital anterior. Sometimes they do not rotate. If it is right occipital posterior, it does not rotate, it becomes occipital posterior. It just stays occipital posterior rather, and it delivers by extension, and that is face to pubis. So occipital posterior will deliver. Most of them they become anterior and deliver. Some of them they stay posterior and they still deliver. Right? So occipital posterior don't say cesarean. Occipital posterior. This question is a favorite INICT question. What is the management of a woman who has come to you in labor with occipital posterior? We say wait and watch. Don't say cesarean section. Okay, wait and watch because most of them will deliver. Right? Mode of delivery in transverse line labor, cesarean section. Transverse line labor, this is that easy bread and butter MCI question. Get your marks. Don't get this wrong. Transverse line labor. Very rarely they're going to ask you that there is a transverse line or a breach at 36 weeks when uterus is relaxed. Patient is not in labor. Then you can do the external cephalic version for breech and for transverse line, both you can do. Now, another hotshot topic which is in all the forums where I'm associated, they're asking, so what is the mode of delivery in a case of an abruption? I've told you categorically in the classes that abruptions will deliver normally. Do an ARM and start oxytocin. ARM makes the uterus contract a little, and the compression of the plasma stops the bleeding. And the process of doing ARM releases prostaglandins, which induces labor, and you give oxytocin, which will promote the contraction. So that is why abruption delivers wonderfully. Yes, if there is a distress in an abruption, yes, the distress becomes the reason for me to do a cesarean section. I don't know, hundreds of abruptions which we have delivered normally. So many. Abruptions, yes, if there's a fetal distress, it becomes an indication for cesarean section. Now, if there is an abruption with DIC, whether they do normal delivery, whether they do cesarean, both ways she's going to bleed and she could be very sick. So none of these become the indication for a cesarean. Cesarean, if the baby is dying, is in distress. If the baby is dead, again, it's not an indication for a cesarean. If the baby is healthy, again, not an indication for a cesarean. Only if he is in distress. So, abruption, do ARM and do a normal delivery. Okay. So, yes, if there is no distress, do a normal delivery. Let's move on and see the other one here. Yes, a 42-year-old woman has irregular bleeding for the last 6 months, and all regular methods of treatment have failed to give her relief. What is the best management of this patient? If there's a question coming in gynae for sure, it is this one. I'm betting on this. If this doesn't come, then okay, fine. I owe you guys a chocolate, but it's going to come. Irregular bleeding. You know what is the main presentation of a woman coming to the Department of Obs and Gynae? with irregular bleeding. Yes, 70% of patients which come to the gynae clinic, they come with too much of bleeding, very less bleeding, bleeding coming delayed, bleeding coming with spotting, bleeding not as much I used to get, bleeding lesser than what I used to get, or bleeding is coming after 3 months or 4 months. So whatever are the complaints of women who are coming to the gynae clinic, most of them are abnormal uterine bleeding. So now this woman has come with abnormal uterine bleeding for the last 6 months, and whatever you know initial method of giving tranexamic acid, NSAIDs, and some of you have been trying hormones sometimes. All of those have not worked properly. So what do you do? Yes, by the way, we don't generally give hormones also without diagnosing. So when a woman has irregular bleeding which is not responding to regular treatment, please, this is that question where you have to do endometrial sampling. Find out what is wrong with the uterus. It could be a malignancy, could be a hyperplasia, could be just infection. It could be a patient who's having a small polyp which is inside the uterus which you're missing. So whatever is the reason, first find that out and then do the treatment. So don't say hysterectomy because she's 45 years. No, it doesn't mean that if there is something wrong with the uterus, you immediately remove it. Only if there's a cancer, you remove it, or something which is untreatable, you remove it. So, whatever the patient comes to you with, whichever type of irregular bleeding she comes to you with, especially after 40 years, please find out what is wrong. So, endometrial sampling or endometrial histopathology, they will write in the exam as a choice. So, how you can do that? You can do it by a pipel biopsy in the OPD, or you can do it by a DNC in the OT, or the best method is the hysteroscopic biopsy. So that is what you do. Okay, please remember this one. Irregular bleeding, do endometrial sampling or endometrial histopathology, or maybe one of these PIPL, DNC, hysteroscopy will come as a choice. Okay, right. Don't miss out on this one. What does co-test for cervical cancer screening include? Co-test means doing two tests. So you do the pap smear and you do the HPV DNA together. If it is done, that is what is co-test, and this co-test is repeated every 5 years. After 30 years, 30 years and beyond, you do a co-test, and if the co-test is fine, you repeat after every 5 years. Simple question. Let's move on. Okay. By the way, what is the best test for the screening of CS cervix? Pap smear, no doubt. What is the cost-effective method? Hardly any cost. Visual inspection under acetic acid. So that is cost-effective, but the best method for screening is still pap smear. Right. All the following are true statements regarding the instrument shown here, except. So this is what is manual vacuum aspiration syringe, the MVA syringe. It is used for suction evacuation. So yes, it is used for MTP 12 weeks on OPD basis. Correct. The first statement is correct. Can be used without electricity. Yes, you can use with this MVA syringe. It is without electricity. It is capacity is 30 ml. That is wrong. That is the answer to this question because the capacity is 60 ml. Pressure generated is around 600 mg. Yes, negative 610 to 660 millimeters of mercury is also correct. So answer is C. Okay, capacity is 60 ml. Okay, read about this also. The suction is applied through this manual vacuum aspirator, and it is put in front with the common cannula. The common cannula is got a color code. It's got a size code. Generally, the common cannula size is the pregnancy in weeks. So if it's a 8 weeks pregnancy, you're going to do an abortion. You're going to use a 8 size common cannula. Let's move on. In CA service, what is the stage in which hydronephrosis of kidney is seen? MCI question, solid one. So, what is the most common stage of CA service presenting to the OPD in our country? And that is also the most common stage where hydronephrosis develops. That is stage 3B. Yes, in stage 3B, which I'm giving you here, please pause and read the staging. This is just half a page of staging and it is the complete staging. I'm not missing anything in the staging. Just pause it and remember this CA service staging. Whichever book you're reading, the CA service staging is given in 2.5 A4 size pages. All of that just is this is the practical assessment of that staging. So please remember this one. And stage 3B, parametrum involved till the pelvic side wall. So can you see this? The parametrum, the black staging I'm showing you in the cervix, the green staging in the vagina, and the blue staging is the parametrum. It is gone till the pelvic side wall. So from the cervix to the level of the pelvic side wall, there are no cancer-free areas. So the ureter gets compressed and that causes a hydronephrosis. So most common stage of CA cervix coming to the OPD, stage 3B, and that causes hydronephrosis. And what is the treatment of CA cervix? Yes, till 2A1 from stage 1 to A1. Yes, till that stage, we can do a radical hysterectomy, which can be the Meeks hysterectomy or the modified radical, which is the Wertheim's hysterectomy. Yes, we Indians tend to do more of Wertheim's, but there are enough gynae oncologists which like to do the Meeks hysterectomy. Both are now, both are radical. So the Meeks hysterectomy is known as the type 3 hysterectomy, the regular radical hysterectomy, but the Wertheim's is the one which is modified. We include lymphadenectomy in the Wertheim, so it is known as a modified radical hysterectomy. Both of these can be done. Mostly in India, we do the type 2 radical or the modified radical hysterectomy. So that is the procedure till 2A1, and beyond 2A2. Beyond 2A2, we'll do the 2A2 and beyond, that is, we do the chemo radiation. And the chemotherapy which you use here is the cisplatin-based chemotherapy. Cisplatin-based. This was also NCI question. Cisplatin-based chemotherapy. Right. Which of the following is the best test for localization of a vesico-vaginal fistula? Look, you tend to answer three swab test here. Please, three swab test is a good OPD test, but if there's a large fistula, all the three swabs will get blue in color. So three swab test is a good OPD test, but the best test to localize the vesico-vaginal fistula is to do a cystoscopy. Okay, so cystoscopy is the best answer. Let's move on. Fatafat. Increased levels of LH for causing ovulation are due to the LH surge. Yes, the LH surge. From the onset of the LH surge, it takes 36 hours to ovulate. From the peak of the LH surge, it is 10 hours to 12 hours which takes to ovulate. And this high LH is because the follicle giving a message to the brain that I'm ready. Why don't you send me LH to rupture? So yes, the follicle sends a message by increasing in size from 15 to 20 millimeters is the mature follicle. It gives information to the brain that I'm making enough estrogen. That means I'm ready. So the high estrogen gives a message to the brain, and brain says, okay, fine, you're ready. I'll send the LH. So how does the brain get to know that the follicle is ready to rupture? Because the follicle makes a lot of estrogen. So estrogen is the cause of the LH surge. All right, guys. There was some recent confusion about this. This is outright basics, guys. Don't get these answers wrong. A postmenopausal woman who is obese, hypertensive, and diabetic. Again, landmark MCI question. A good, fat, healthy woman with diabetes and hypertension. Now, this is not the typical poor Indian woman living in the villages. This is the fat, diabetic woman who has got hypertension in a well-to-do society of India or any other part of the world. So, well-to-do women, diabetes and hypertension. Don't say CA cervix, say CA endometrium. So, you will be asked questions on CA endometrium also, not always only on CA cervix. Yes, in CA cervix is the commonest gynecological cancer in India. Correct. But the question on CA endometrium will come with this language. So this question don't get wrong. This is a case of CA endometrium. So when there is hyperplasia of the endometrium, CA endometrium question is over. I'm just trying to give you a good revision. So hyperplasia of the endometrium causes CA endometrium, right? So simple hyperplasia of the endometrium and no atypia causes CA endometrium in 1% of cases. Complex hyperplasia causes endometrial cancer in 3% of cases. Simple endometrial hyperplasia with atypical cells causes cancer in 8% of cases. And complex endometrial hyperplasia with atypia causes cancer in 29% of cases. So, what is the treatment? Yes, the treatment of hyperplasia without atypia, chance of cancer is less, is to reverse the action of the hormone which is causing the hyperplasia. So what causes hyperplasia? Estrogen. And what acts opposite to the estrogen by causing secretion and stabilization? Yes, that's the word. That is progesterone. This came in all the exams where I predicted. It came in Jan 2025, and it's not come in the July 25 exam. 50% chance that it's going to come this time. That hyperplasia management without atypia is progesterone. With atypia, yes, now with atypia, chance is becoming almost 29%. So, yes, here you say a hysterectomy. Here you say a hysterectomy. All right, guys, let's move on. Next one. Best treatment for osteoporosis of women beyond 60 years of age. Question, guys. INICT question, November 2021. After this question, the arguments have fairly settled. AIMS, JIPMER, PGI, people asking you what is the management of osteoporosis after 60 years of age. So after 60 years of age, I agree it is bisphosphonates. Why did they ask you after 60 years? Because before 60 years, that is from 50 years to 60 years, there is some other drug. Why did they ask you after 60 years? Because before 60 years, it is hormone replacement therapy. Estrogen is the best management of osteoporosis, prevention and treatment before 60 years. So, yes, when a woman is at 50 and she's got osteoporosis, prevention to be done and treatment to be done, we always say estrogens, hormone replacement therapy. That's why this question came in NICT, and that's why it came because it is also written in your books. Shaw's Gynecology. See, osteoporosis treatment. Read with me. Look, natural estrogen, progesterone, tibolone, raloxifene are beneficial in osteoporosis if it occurs early in menopause. Thanks to my favorite book, Shaw's Gynecology. If it occurs early in the menopause, it is estrogen. Osteoporosis occurring late in menopause benefits from bisphosphonates. See the summary here. Prophylaxis of osteoporosis. Estrogen alone, if a woman has hysterectomy, then estrogen alone. That is the prevention of osteoporosis. Estrogen plus progesterone if the uterus is intact. Then tibolone comes, and then raloxifene comes, and even soybean comes before that. And finally, bisphosphonates come. Finally, when they're writing bisphosphonates, they're reminding you for late osteoporosis, just in case you forgot, only for late osteoporosis. Then turn the page. Other drugs for osteoporosis. In the other drugs, the fourth drug is bisphosphonate. And in that bisphosphonate, finally, when it is mentioned bisphosphonate, what are they writing? They are writing it is recommended that HRT should be prescribed in early menopausal age. After 60 years, osteoporosis should be managed with bisphosphonates. As crystal clear as this. Black and white, guys. Shaw's Book of Gynecology, your reference book, is writing it so clear. So, yes, you have to know your core basics. I agree there's a controversy about bisphosphonates and estrogens. In our postgraduate circles, we have this day in and day out discussion going on with the postgraduates amongst my friends also. Royal College is very happy giving bisphosphonates. American College wants to give only estrogens. What are you going to follow? You're going to follow what is written in the books and what is done in the OPDs. So gynecologists always believe on estrogens. Yes, we give tibolone a lot. Tibolone is got a synthetic estrogen with the progestation metabolite. So that's my favorite drug to so many patients we keep. I run a HRT clinic in my hospital. So, guys, do not change this answer simply because you've seen it from so many sources. Okay, guys, remember from the time of menopause, 50 years to 60, it's always estrogens because it's got added benefit of taking care of the hot flushes and the mood swings and the vaginal atrophy and the osteoporosis. After 60 years, estrogen can be detrimental. Yes, I agree. So after 10 years, you cannot give estrogen. So that's why after 60 years, it is bisphosphonates. End of discussion. Let's move on, guys. Another one. How do you know that the pessary given for prolapse uterus is adequate? So the uterus, if it is having a, if it is coming out in a prolapse, then I don't want the uterus to come out, especially if the woman is old. And the uterus coming out can also cause the bladder to evert out and cause retention of urine. So push the uterus back inside and keep a pessary here. Keep a pessary here. That pessary, all right, that pessary here is going to make sure that the uterus doesn't come out and she can have a dignity of passing urine by herself without coming to the hospital and getting catheterized. Or sometimes she has to push the uterus inside with her hand and then only urinate, and half of the urine falls on her hand. So, yes, pessary treatment is good temporary treatment. How do you know it is adequate? After putting the pessary, she should not have pain. She should not have pain. And then, after putting the pessary, when she strains, the uterus should not come out. So that is what is telling us that it's an adequate pessary. Let's move on. Next one. Oh, I'm stopping here, guys. I want you guys to understand this was a quick fire revision of all the common topics which are coming in the exams. There might be a few more. Let's see if I can do another session before the exams. But yes, now is the time to just concentrate on your notes, whichever 19 teachers you write. Okay, there are so many of us teaching you. You may like a few more than the others. So stick to your favorite teachers and read only their notes now. Do not pick up a new book. Do not try to do a new question bank. Do not get influenced by your friend who's done all the question banks. You're going to only confuse yourselves. If you avoid question banks for now and look only to the PYQs, especially the teachers who are teaching you, they are explaining the PYQs because sometimes the choices are not coming properly. So we're trying to help you that maybe somebody did not recall the choices properly. My friend, this question, this is the best answer. So your teacher can teach you best. Okay. So I'm not saying the books are bad. I'm just saying you may get confused because there's so many sources in the market. So I want you guys to stick to your favorite teachers. All 19 subjects, read the notes for the time being, and simply pass the exam Because once you read 19 notes on 16th night when you're sleeping and 17th morning when you're getting up, you have a smile on your face. I've completed my course, so I'm going to do a good exam. Do that, guys. And 14th of Feb, have a fantastic Valentine's Day because you're all going to pass. Best wishes.